So in the next 15 minutes, which are allotted to me, I'm going to be discussing vitreoretinal interface disease. And it's really in two parts. The first one is like to understand what is vitreoretinal interface disease, and then try to look together what are the options that we have in managing the anomalous posterior vitreous detachments. And already Felipe very nicely alluded to that about what happens to the vitreous body. Just to understand a few fundamental things is that the vitreous is really mainly water. 90% is water and some macromolecules. But what really gives the structure to the vitreous is two things. The hyaluronic acid, which stabilizes a framework of fibrils. And this is what gives the jelly its stability and its structure. And the vitreoretinal interface itself is really at the level of the ILM, and don't think only of the macula. This is really all over. Think of 3D of the retina. It's all at the level of the internal limiting membrane. This is where the connection between the vitreous cortex and the retina is happening. And that vitreoretinal interface is by some macromolecules at the level of the ILM, mainly fibronectin and laminin. Some areas are loosely attached and between the cortex and the ILM, and we can remove it easy during surgery, we know that. But some other areas are known to be very firmly attached. The vitreous base, you cannot undo it. And it becomes wider with age. It's important to know that the vitreous base advances posteriorly with age. At the equator, maybe a little bit, over the blood vessels, but definitely more importantly at the level of the optic disc and the macula. And sometimes during surgery, we pull so hard until we induce the posterior vitreous detachment. And then at the macula, at the level of the macula, and this is where the importance of all what we will discuss later about pathology and management. The aging was mentioned already. A younger age, less than 30, is very homogeneous, and then age start taking its toll, and the fibrils start becoming thicker, much more visible. Contraction of the vitreous mass and liquefaction. All this sets into as you can see to the left, this is an older vitreous with much more fibrils, and the patient obviously would be seeing floaters. But the important thing is that this is what's going to lead to the event of posterior vitreous detachment, which is the crucial event in the life, really, of the vitreoretinal interface, as we will discuss in a few minutes. So this change, this dissociation between the hyaluronic acid and the fibrils make the stability of the vitreous much less, and then one day the vitreous is going to separate by the cortex, the vitreous cortex separating from the ILM. And if that happens, like you can see there on the left of the slide, complete vitreous separation except at the vitreous base, then there is really no problem, no pathology. And it is really when there is an anomalous separation that problems start happening or complications, and not only at the level of the macula, as we will see from the slides. The problem of vitreoretinal interface, if it is abnormal, it gives rise to many problems. The vitreous base will start from the right of the slide. At the vitreous base, if there are problems with that separation, then you can start getting breaks. At the level of the optic disc, sometimes it pulls on vessels and can lead to vitreous hemorrhage. But really, the important for our talk here is what happens at the level of the macula. You can have problem with epiretinal membrane. If there is the vitreous has separated with fibrosis, you can have foveal retinoschisis, and the important part for this talk is the focal vitreomacular which is anomalous separation and can lead to vitreomacular traction. And then that can progress to a macular hole. And this is really what we'll talk about when we discuss the symptoms, what you will see clinically, and the options of management. It's important that we talk the same language, and the International Vitreomacular Traction Study Group in 2013 finally made it possible for us to really be talking about the same thing rather than giving different names. And this is the terms that we use for the conditions or the various stages, and I will show you now on the OCT. If the vitreous is not causing any structural abnormality in the retina, it's still adherent in the center of the macula, but separated elsewhere. This is called vitreomacular adhesion, and it can be focal or broad. And if it causes any structural abnormality, we call it vitreomacular traction. And that also can be focal or broad with the measurements of 1,500 microns that you can see. If it is less, it's focal. If it's more, it's broad. And after that, the next thing is the full thickness macular hole, whether small, medium, or large. That changed, obviously, the old classification of gas that we used to say stage 1, stage 2 macular hole. You should not use this terminology. You really should learn this one, which is, and this is the one to use because this corresponds to what is going on in the natural history of this problem. Vitreomacular adhesion on top, then some traction, then it can lead to full thickness macular hole. The full thickness macular hole can enlarge, and then if the vitreous attachment lifts completely, you get into the lowest one without any vitreomacular adhesion, and those usually are larger holes. The VMA, or vitreomacular adhesion, is the separation, therefore, as we discussed, the separation of the cortex from the retina, except if it stays at the level of the macula, then it causes, then it is the condition that we call VMA. On the left, you can see it here on a scan as well as schematically represented. There is no adhesion at all. If it's adherent but not causing any structural abnormality, then we call it vitreomacular adhesion. Now, the VMA can then progress to vitreomacular traction. Not all of them will progress, obviously, but then just see the various steps. It can lead to vitreomacular traction. The vitreomacular traction can increase, or it can lift spontaneously. And then when the vitreomacular traction increases, it can go to vitreomacular to macular hole, or it can also lift spontaneously. So all these scenarios can occur. It is important to know what is the percentage that the lifting spontaneously is going to happen, because this will help us decide about the management. Do we offer treatment or do we wait? When it is vitreomacular adhesion, obviously, usually there is no symptoms, and it is only when it is vitreomacular traction that is symptomatic. You have to know that only about 10% from then on are going to lift spontaneously. And this is obviously to be taken into consideration when you decide about treatment. Then once macular hole develops, also the fact this is to get better spontaneously is very, very infrequent, and that's why we all would go to intervention. The diagnosis of these conditions, although when we look, we can recognize what is probably happening, is really ultimately by an OCT. I used always to tell the residents and the fellows that you really have to look very carefully and try to diagnose things by ophthalmoscopy, but not in this condition. Really, OCT is the way, and if there is no structural abnormality in the retina, is vitreomacular adhesion. If there is structural abnormality, even if it is very little, pinching of the retina, then this is to be labeled as vitreomacular traction. So this would be VMA, vitreomacular adhesion. This would be vitreomacular traction, obviously, because there is structural abnormality. Now, if you can have vitreomacular traction, which is not symptomatic. It is possible if the outer layers are good and the pulling is very little. But once it is symptomatic, it will give rise to either the patient come complaining of metamorphopsia or of decreased visual acuity. And in these cases, we have to offer the patient something to be done about his condition. Now, what are the options? This is the second part. The options that we have to manage vitreomacular traction now is pharmacological vitreolysis, pneumatic vitreolysis, or pars-plana vitrectomy. The pharmacological vitreolysis, the only product that is available to do that is the Jetrea or the ochriplasmin, which is truncated form of human plasmin. And we obviously inject it, delivered by intravitreal injection. And what it does, basically, it acts on the fibronectin and laminin, and it induces splitting of the vitreous cortex away from the internal limiting membrane. That obviously when it works. Because when you look at the efficacy of Jetrea or ochloplasmin, all the patients together in the study, the success was in 26%. Obviously, compared to the 10% that received vehicle only, definitely it is significant. There is statistically significant, but it is a little bit on the disappointing side. Subgroup analysis led to a recommendation of if you treat patients who only have focal adhesion and no epiretinal membrane, that the success rate might go up a little bit, up to 40%. But, you know, 40% is a little also disappointing. With, from the studies themselves, a large number of possible complications. Importantly, that you can have a decrease in visual acuity, affected electroretinogram, and we don't really know for those when it happens, why it happens. In addition, this needs special handling with freezer and reconstitution, although the company says that they will offer now in the future the Jetrea that doesn't need to be reconstituted. We'll see. I'll just share with you quickly, this was an 82-year-old female, and one eye has macular hole that was treated elsewhere. And the other eye, I want to share with you, there's the other eye. So the left eye was not successful. She cannot position. She was really overweight. And I found there is a little bit of pinching of the inner layer, and the profile is abnormal. So this is a VMT, but 20/20 vision, and you observe. And as the months passing by, you can tell that there is slowly elevation, and vision is coming down to 20/25 and 20/30. Surgery is not very good for this patient because she cannot position, 82-year-old, and she could not put face down at all. And in this case, I thought that Jetrea was indeed would be good for her, and that's what I did. And as you can see, it lifted. But the very seldom use this product really. The other option is the pneumatic vitreolysis, and this is a very interesting option, and I think it's important to know of its existence. You inject intravitreally 0.3 cc of C3F8. Some people use SF6, the majority use C3F8, and you might need to paracentesis, and then you ask the patient to do the bird feeding maneuver, which is like to move down the head several times in the first day or two, and the success rate collectively of this has been about 86% inducing a PVD. It is a really good success rate, considering that you're just going to be injecting in the clinic a gas bubble. And this is such, I'm going to move quickly with those. This is such a patient that came with VMT, and I injected the gas, and she got really better with improved vision. And the last modality, obviously, is porcipinal vitrectomy. Any of the gauges can go. This is perfect for 27 gauge. The triamcene alone helps you visualize the vitreous. And it is important, in my mind, that you don't pull on the middle of the fovea, because you can induce a macular hole. It is really easy and effective to go and, after you visualize the vitreous, to circumcise it, the central area, with your vitrector. In this case, you'll just lift the problem. Whether to peel ILM or not to peel ILM is really a discussion, but it's not the most important thing for the success of these cases. The most important thing is to sever the traction that's coming from the vitreous. And you know, this is just an example of such a patient, one of my patients for whom I've done this porcipinal vitrectomy. So in summary, the vitreomacular traction can lead to visual loss. Spontaneous improvement is only in 10%, so really those deserve to be treated, to be offered one of the options. When visual loss occurs, it's preferable to treat. The aim of the treatment is lifting of the vitreoretinal adhesion. The modalities of the treatment available are pharmacological vitreolysis. This is really not frequently used. Pneumatic vitreolysis seems to be a very practical and convenient option, office-based, and definitely the 100% success rate with porcipinal vitrectomy, and it gives excellent results. Thank you so much for your attention.